Αγαπητοί φίλοι, καλησπέρα σας. Απόψε μία νέα εκπομπή Θέματα Υγείας μαζί σας, όπως κάθε Κυριακή. Και έχουμε μία γνώριμη κοντά μας, την καθηγήτρια Δρ Ελένη Παλαζίδου. Είχαμε πει πριν λίγες εβδομάδες ότι θέλουμε να κάνουμε ένα sequel εκπομπών σχετικά με ψυχιατρικά θέματα. Είναι θέματα σημαντικά, είναι θέματα που μαστίζουν την κοινωνία. Και επειδή υπήρχαν πάρα πολλές παθήσεις να συζητήσουμε και να αναλύσουμε, αποφασίσαμε με την κυρία Παλαζίδου να μας δώσει από τον πολύτιμο χρόνο της και να συζητήσουμε διάφορες παθήσεις σε διαφορετικές εκπομπές. Λοιπόν, σήμερα θα μιλήσουμε για δύο πολύ ιδιαίτερα θέματα. Perinatal disorders και ψύχωση και σχιζοφρένεια. Είναι δυστυχώς από τις παθήσεις που είναι ιδιαίτερα συνήθεις και σίγουρα όχι απλά μία ειδικός, αλλά μία καθηγήτρια Πανεπιστημίου Ψυχιατρικής έχει πάρα πολλά να μας πει από αυτού. Θα πω πάλι δύο πράγματα. Καλώς ήρθατε και πάλι. Ευχαριστούμε πάρα πολύ. Διδάσκοντας μεταξύ Λονδίνου και Κύπρου, μας έχετε χαρίσει από τον πολύτιμο χρόνο σας υπέροχες εκπομπές. Άλλες δύο μαζί θα κάνουμε σήμερα. Στο πρώτο λοιπόν αυτό μέρος της εκπομπής που θα δουν οι τηλεθεατές μας σήμερα, θα μιλήσετε για αυτά που προλογίσαμε, αλλά να πω και εγώ δύο λόγια για εσάς. Η κυρία Παλαζίδου γεννήθηκε στην Κύπρο, μεγάλωσε εκεί, πήγε σχολείο στη Λευκοσία, σπούδασε στην ιατρική στη Σόφια και στην πορεία ήρθε στην Αγγλία, έκανε ειδικότητα στο Maudsley Hospital και στο Ινστιτούτο Ψυχιατρικής του Λονδίνου. Είναι ψυχίατρος ενηλίκων κατά κύριο λόγο και ασκεί την ειδικότητά της 20 και πλέον έτη. Είναι ανεξάρτητη consultant ή αντίστοιχα διευθύντρια, όπως τα λέγαμε στην Ελλάδα. Στο Ηνωμένο Βασίλειο κάνει έρευνα και διδάσκει στο Barts and the London School of Medicine, Queen Mary University. Στην Κύπρο στο St. George's Medical School, University of Nicosia. Εργάζεται με μια ιδιαίτερη ομάδα, όπως είχα αναφέρει στο παρελθόν, με τους Σομαλούς, γιατί έχουν κάποια ιδιαίτερα ψυχιατρικά θέματα και έχει αφοσιωθεί σε αυτό η κυρία Παλαζίδου. Είναι πρόεδρος της Ελληνικής ψυχιατρικής εταιρείας στην Αγγλία και πρόεδρος της Ένωσης Κυπρίων Αγγλίας και έχει διατελέσει πρόεδρος σε πάρα πολλές άλλες. Έχετε ένα βιογραφικό, θα μιλάω μια εκπομπή ολόκληρη μόνο γι' αυτό. Κάνει έρευνα, δημοσιεύσεις, είναι συγγραφέας βιβλίων. Έχει ένα ιδιαίτερο ενδιαφέρον στην κατάθλιψη και στις διπολικές διαταραχές και στην ψυχοφαρμακολογία. Αυτά τα ολίγα από τα πολλά που σας πλαισιώνουν. Σας δίνω το λόγο και πάλι καλώς ήρθατε και σας ευχαριστώ πάρα πολύ για αυτά που θα μας πείτε σήμερα, γιατί ξέρω ότι θα είναι πολύ σημαντικά.
Και εγώ ευχαριστώ, γιατί με ενδιαφέρει ιδιαίτερα η ενημέρωση του κοινού, ιδιαίτερα της δικής μας της παροικίας, και εδώ φυσικά και στην Κύπρο, σχετικά με τις ψυχιατρικές ασθένειες και προσπαθώ όσο μπορώ να φροντίσω να χαθεί πια αυτό το στίγμα της ψυχιατρικής ασθένειας και να μπορεί ο κόσμος να βλέπει ψυχιατρική ασθένεια όπως οποιαδήποτε άλλη ασθένεια.
Ναι.
Γιατί είναι και οι ψυχιατρικές ασθένειες θεραπεύσιμες και ελεγχόμενες.
Αλλά είναι ταμπού για τις κοινωνίες μας.
Είναι ταμπού και αν δεν πλησιάσει κάποιος τους ειδικούς για βοήθεια, δεν θα θεραπευτεί φυσικά. Οπότε ελπίζω αυτό να βοηθήσει τουλάχιστον λίγο.
Αυτό είναι και σκοπός της εκπομπής μας. Και εμείς ανιδιοτελώς εργαζόμαστε με μια ομάδα ανθρώπων και για μένα φανταστείτε να βρω ανθρώπους που έχουν διακριθεί από τις γνώσεις τους, από τις δραστηριότητές τους στην ειδικότητά τους, να τους φέρω να μιλήσουμε σε ένα ευρύ κοινό που μέσω των μέσων κοινωνικής δικτύωσης και γενικότερα του διαδικτύου μπορούν να μας παρακολουθήσουν οπουδήποτε και αν μη τι άλλο τους προσφέρουμε γνώσεις και συμβουλές. Και να τους δώσουμε και το έναυσμα να έχουν το θάρρος να ζητήσουν βοήθεια όταν κρίνουν ότι τη χρειάζονται. Γιατί δεν έχουμε το θάρρος ακόμη να πούμε ότι έχουμε κάποιο ψυχιατρικό πρόβλημα.
Ναι, ναι.
Πείτε μας, ίσως ο κόσμος δεν ξέρει, είπαμε perinatal disorders, περιγενετικές διαταραχές. Θέλετε να μας το αναλύσετε. Επίσης να πω, συγγνώμη πριν ξεκινήσετε, επειδή η κυρία Παλαζίδου διδάσκει πάνω από 20 χρόνια και ζείτε εδώ, ενδεχομένως κατά τη διάρκεια της συζήτησεώς μας να είναι πολύ πιο εύκολο να εκφραστεί στην αγγλική. Οπότε μπορείτε να μιλήσετε σε όποια γλώσσα αισθάνεστε πιο άνετα.
Ευχαριστώ. Αν μπορώ να μιλήσω κυρίως στην αγγλική γλώσσα,
το κατανοώ, γι' αυτό και το είπα.
Θα είναι λίγο πιο εύκολο για μένα όσο αφορά ειδικά την ορολογία.
Έτσι.
Αλλά επίσης ελπίζω να βοηθήσει και το κοινό, γιατί τουλάχιστον οι νέες γενιές έχουν την αγγλική γλώσσα σαν πρώτη γλώσσα και ελπίζω να είναι πιο εύκολο και για αυτούς.
Ωραία.
Το θέμα μας είναι perinatal disorders και το πρότεινα αυτό γιατί έχουμε ήδη καλύψει στις δύο προηγούμενες συνεντεύξεις θέματα ψυχιατρικών ασθενειών, ιδιαίτερα όσο αφορά κατάθλιψη και διπολική ασθένεια, οι οποίες έχουν στενή σχέση με την περίοδο, οι οποίες, φυσικά η κατάθλιψη μόνο, όχι και η διπολική, αλλά η κατάθλιψη είναι πιο συχνή στις γυναίκες εν σχέση με τους άντρες και μιλούμε για γυναίκες από εφηβική ηλικία μέχρι τη μηνόπαυση. Στην παιδική ηλικία και μετά τη μηνόπαυση δεν υπάρχει διαφορά. Αλλά σε αυτή την περίοδο που η γυναίκα μπορεί να μείνει έγκυος και να αποκτήσει παιδί, είναι πιο ευαίσθητη σε αυτή την ασθένεια ιδιαίτερα. Και επίσης η περίοδος εγκυμοσύνης και ειδικά σύντομα μετά την γέννηση, τη γέννα, είναι οι ψυχικές διαταραχές είναι σε πιο ψηλό επίπεδο. Τώρα, αν μπορέσω να αλλάξω στα αγγλικά για να εξηγήσω λίγο περισσότερο. We have for many years recognized, and from ancient times people recognized that women after childbirth were vulnerable to mental disorders. And those of you who, perhaps the older women, will recall that after childbirth in the old days, mothers wouldn't be left alone for the first 40 days because there was a recognition some things can go wrong. And that is because it was recognized women can become mentally unwell during that time, in addition to other problems, obviously physical and other difficulties. So for a variety of reasons, which include possible predisposition or the existence of a particular condition, which then during the pregnancy and particularly after childbirth can emerge, can be triggered off by the hormonal changes in the body. But also because of psychological and social effects of having a new life and into the family and the stress involved with that, however happy an event it is. Stress can be happy stress as well, not just unhappy stress. So psychiatric conditions, women then are more vulnerable to psychiatric conditions during that period. These conditions present, we now know that the current evidence shows that these conditions are exactly the same as the generally known psychiatric conditions. They are called perinatal because they occur at that particular time, just before or after childbirth. So it's just the timing of it that gives them that title. I have to say that if a woman has recently given birth and feels a little bit tearful, please don't panic. It is common. 85% of women in the first 4 to 5 days after childbirth become tearful. For no reason. They can't understand why. They are very happy to have the baby, but they still can be tearful. This is very benign. As I said, it's very common, and it wears off within a few days, so there's nothing to worry about that. However, in about 10 to 15% of women after childbirth, there can be a more severe form of low mood in the form of depression, depressive illness, as we described it in the last lecture. And in a very small percentage of women, something like 0.1 to 0.2. So this is a minute number. Don't get alarmed. It's a minute number of women, but it's important to be aware it can happen. There can be a condition which we call postpartum psychosis. And I will explain in a short while what we mean by psychosis. But this is a very serious condition for the mother, and they may have implications in terms of the care of the baby. So it is important to know about it and to seek help straight away. Now, as I said before, why do women become unwell around that time after childbirth or just before? It's because of the major hormonal changes in the body, which can be extremely high during the end of the pregnancy, and suddenly after childbirth they just drop dramatically down. So obviously this disturbs the body. And these hormones affect the way our brain works the efficiency of the brain function. And this is why in some cases there may be psychiatric symptoms. Now, there are no difference between women who have a psychiatric illness and those who don't in terms of the levels of the hormones. It's just that the effect of the hormones on the brain is different.
But those who have a psychiatric disease beforehand
are more vulnerable.
Exactly.
Are more vulnerable, and therefore it's important, certainly with the patients under my care, if they want to get pregnant, I always advise women to plan ahead. So we plan it together. If they're on medication, for example, what do we do about this? And then if we think that there is a high risk, then we follow them through, and immediately after, towards the end of the pregnancy and immediately after, we have close contact to make sure we pick up any early signs of illness, and we treat it very effectively and very promptly. And that's very important to do with your doctor, your family doctor, your GP primarily. But for those of you who are linked to psychiatric services, obviously make sure you discuss it with your psychiatrist.
We need the backup because it's not easy to treat these people, especially pregnancy. If you need to give medications during pregnancy, you can't really do it in primary care. You have to be very cautious.
It's very important, yes, that the specialist services are involved if there is a known history. But it's important for the primary care practitioners to be highly alert to the possibility of a mental health problem, even in a woman who never had any problems before. Just to keep an eye on them, and if there's any suspicion of problems, then to take action.
Indeed.
So I won't talk much more about the causes of it, unless you think you would like me to say.
Just to highlight the most important.
We did mention the hormonal changes. We mentioned genetic vulnerability. So if people have a family history, then obviously to be aware and careful. Obviously people who are more vulnerable to becoming unwell, particularly depressed after childbirth, would be people who have family problems, no supports, financial problems, any stressors really. The environment is not conducive to a sort of a relaxed life, and the stress of having to care for a newborn, particularly if it's the first time, and mothers are unsure as to how to manage and whether they're doing a good job, and they're anxious about perhaps not doing the right things and so on. So all these stresses are not helpful, and it's good for family and other friends and people to support the mother. Now, before we go on to how do we manage that? First, sorry, before I go, I move on to the treatment. If I could say a few things about, and this is very important, women who had in the past depression after childbirth, or a manic episode after childbirth, or a psychosis. The psychosis usually presents with a lot of affective features, with a lot of depression or mania at the same time as the delusions and hallucinations which are associated with psychosis. It's important to try and delay further pregnancy for a while, at least for 3 years, because because the risk of having the same problem after a subsequent childbirth is high. In the first 3 years, it's up to 50%. So if possible, it's best to postpone it to make sure that they have a long period of stability and normality, and there are no stressors around them, and then obviously they have the necessary supports around them when they go on to their next pregnancy. It doesn't mean they shouldn't have another baby, but just to be careful as to the timing of the next pregnancy.
All right. They decide that with the therapist, I suppose.
I think it's important to discuss that with your psychiatrist, yes. Usually the psychiatrist will have a discussion with you about it, but just in case it hasn't been suggested, ask your psychiatrist and make sure you're clear about what your condition is like and what the chances are of you having another episode after childbirth.
A good advice.
Yeah.
Okay, and what about treatment?
Now, in terms of treatment, most commonly women who have depression after childbirth, so antidepressants are obviously the best treatment. And if the condition is not very severe, if it's mild to moderate, it's useful to consider psychological treatments alone in the form of cognitive behavioral therapy. But if that doesn't seem to be working, then obviously antidepressant drugs are necessary. And then again, there should be a discussion with your doctor in terms of breastfeeding and how this may affect the baby.
That was my next question.
Yeah. So some antidepressants are okay to have while breastfeeding, and maybe you could time taking the antidepressant after you breastfeed, so the levels are low, and then so you wait. You breastfeed just before you're due for your next tablet of antidepressant.
All right,
so at that time the level will be low.
So if you breastfeed in the morning early, before you take the tablet around 8 o'clock,
yeah, it's better before, not just
3
after.
hours later, when newborns literally they get fed again, is that safe?
Well, it depends what medication, and I don't want to go to individual medications, but I think this could be some medications are better than others in that sense. So it's important to discuss that with your psychiatrist, and they will advise you what is the best medication in terms of that. But again, in terms of the breastfeeding, if you could perhaps collect milk and keep it to give the baby later. So express as much milk as you can at times that you before taking the medication, so the levels are low, and then use it for as long as you can until the next time you need to breastfeed. So there are practical ways of making sure the baby is as exposed as little as possible to the medication. And this brings me also to the issue of using medication during pregnancy, and I think a lot of women may be wondering, what do I do if I get pregnant and have medication?
I'll tell you, most of my patients stop them, despite the fact that they tell them you must take them from the mental health team. They stop them because they are concerned.
Yeah. I think this is why I said before, it's so important if you already have a condition and you are on medication to plan ahead. So you can discuss it with your doctor before you get pregnant. So you use contraception, discuss with the doctor to get to the point where your condition is stable, and you may not need medication for a brief period of time for the duration of the pregnancy. But this is quite often not the case. Sometimes it's possible, but not always possible. So if you are already on medication, then the higher risk is in the first three months for the baby, not for the mother.
During organogenesis, obviously.
Yes. And so perhaps you could be kept off the medication for those first 3 months. But again, if you become unwell, then maybe your own life may be at risk if you are not on medication, depending what your condition is. Or the baby's life, if you become very depressed and you neglect yourself, then the baby's health will be affected. So there's got to be a good assessment of the risks and benefits of staying with the medication, and that can only be in collaboration with a specialist. So have a frank and honest discussion with the doctor, ask all the questions you possibly have, explain all your fears, and listen to what the specialist says to you. And I find that most women welcome that, and it works, and we are able to have a package of treatment for each individual case adapted to the needs of that individual person. And all psychiatrists are able to do that with you as their patient. So please don't stop the medication suddenly on finding out you're pregnant. I appreciate that a lot of people don't plan the pregnancy, it just happens sometimes. And then you want to keep the pregnancy, then you can still have a conversation with a psychiatrist and discuss how best to manage that. Don't stop the medication suddenly, because if you do that, then your illness may flare up, and then you become unwell, the baby's health can potentially be affected. So
and the safety, I suppose, because if the mom
and of
becomes
course, absolutely the safety, and I
psychotic.
Yeah, I should say that obviously the family need to be very aware of the presence of the illness in the mother. It's very rare, but it can happen sometimes that the very sick mother may harm the baby because they are so unwell at the time. I don't want to scare people. This is extremely uncommon. But it is important for the mother to be supervised if there is a risk to the baby. So if the mother is psychosis and has delusions about the baby, then obviously it's important that the baby is taken care of. And these days in the UK at least, we have centers which are called mother and baby centers. So mothers who've recently had a baby or about to have a baby sometimes can be transferred with the baby to the unit, so they can continue caring for the baby, breastfeeding, looking after the baby, doing all the things they need to do as mothers with the support of trained staff. So everybody's safe and the mother can relax and take care of her own health as well as caring for the baby. Yeah, with supervision.
And maybe the feeling that you are supported by specialists make you feel more confident and safe.
Absolutely, and you also the support particularly if you're a first-time mother, or you also learn how to care for the baby in a supportive, friendly environment which is non-judgmental. People understand what is going on and nobody's going to accuse you or criticize you, they will understand. And there was a very good, I was very impressed with the way one of the soaps on television handled this particular situation without promoting EastEnders. I think they did a very good job of showing a mother who became mentally ill and how she was able to look after her baby in hospital, and everything turned out very well in the end. So I think it's good that the media cover these particular situations and inform the public.
Definitely. Shall we say a few things about psychosis and schizophrenia, which unfortunately are also quite common. We see them very often in young people, so maybe it's good to tell us a few things to highlight.
Yeah. I wanted to start with explaining to people what psychosis is.
Yes.
Because I think if people are unclear, and psychiatrists sometimes are accused of labeling people as psychotic and that we get it wrong. So I want to explain it.
All right, let's make it clear then.
Yeah. So being psychotic means having abnormal beliefs and experiencing things that out of the normal, the reality of our lives. So the person becomes psychotic when they lose touch of that reality. So they believe things that normally when they're well they wouldn't believe. And the definition of a delusion, sort of being having an abnormal belief and being psychotic, that having a delusion means you are in a psychotic state, means that you believe certain things that are unreal and not true. Other people from the same background, the same education, culture, religion, ethnicity and so on would not think them to be true. And that belief is so strong that whatever evidence there is against it, the person with the delusion cannot accept it. So for example, somebody may believe that aliens have landed in London and have taken over the bodies of some of their family, of the person's family. So their family are not their real parents or siblings, they are aliens who've taken over. Now of course there are lots of films about this, but a person who normally would not believe that is possible to happen. So that is a delusion.
But it's beyond belief.
It's an abnormal belief, yes.
Yeah, exactly.
Yes. And also in a psychotic state, people have what we call abnormal experiences. So they may hear things that other people cannot hear.
Hallucinations.
They have hallucinations, auditory hallucinations, hearing things. But they may see things, have visual hallucinations, or they may have hallucinations of smell, of taste, or of touch. But the most common ones are the hearing hallucinations and the visual ones, but most commonly hearing hallucinations. So these two abnormalities, having hallucinations and having delusions, means somebody is in a psychotic state. I hope I have sort of explained it well.
It's quite clear, I think, and even for the viewers, I believe.
People can, as we said before, can write in and ask questions if they want. I'll be very happy to explain. Now, psychotic states, people commonly associate them with schizophrenia. And schizophrenia, of course, is the best known psychotic illness. But psychotic states can occur also in the context of depression. So in severe depression, there may be delusions and hallucinations. They occur in the context of mania. So in a bipolar disorder, either in depression or mania, there can be delusions or hallucinations.
They become aggressive as well?
Depending what experiences people have, may become aggressive. They become frightened that somebody is going to harm them. They may lash out. People with psychosis are not normally aggressive people, or people with schizophrenia are not normally aggressive people. And I know the media have made a big deal about people with schizophrenia killing other people, but this is an extremely small minority of people. So please do not associate mental illness with danger. In fact, the mentally ill are more at risk by us, the rest of us, that they are a risk to us.
You see, it happens on the news, on the papers. A maniac who killed is a killer, a serial killer. It's always there are word expressions which are used. The maniac, the psychopath. So
thanks for mentioning that. Yes, that perhaps I could clarify that the lay terms are very different from the medical terms. So people talk about this psychotic man or woman who has killed somebody. This is not what they mean. They understand somebody who's in a state of high arousal, extremely angry and aggressive. That is not psychosis. I've already explained what psychosis is. It's having delusions or hallucinations. It is not being aggressive and dangerous to others. Okay, so they're not directly linked, the two cases. Also, the term manic. Manic is not the person who's extremely angry again and aggressive as the general public usually refers to. Manic is somebody who's highly elated, who's on top of the world, feel extremely happy, they're full of energy and so on. I explained this state the last time in the last lecture, so please go back to the lecture and look at how mania presents. It's very different from what you may think it may be. And also, to explain that being psychopathic is different from being psychotic. So psychopathic is a personality disorder. Psychopathy is a personality disorder. Somebody is the way they are, their character is such that they lose the ability, they don't have the ability to show empathy for the other human beings. So then these people are likely to cause harm to other people, either steal from them or do more serious harm to them without feeling sorry, feeling any empathy for the victim. That is not psychosis. That is a personality disorder, a form of personality disorder which is uncommon, but it's a completely separate category. So I hope I have made that distinction clear, but as I said, please feel free to ask questions. I also, before moving on, I also wanted to mention that the psychotic state can be also drug-induced. So somebody who takes cocaine or other stimulants, amphetamines, LSD and cannabis and so on, they can experience paranoid delusions and they can hear voices, they can see things, so they can go into a temporary psychotic state. And with chronic use, there may be a more persistent psychotic state. Then other brain disorders like inflammation of the brain, like say systemic lupus erythematosus, can cause psychiatric problems, including psychotic experiences. in epilepsy sometimes. They're uncommon, these are very uncommon states, but a doctor will obviously check that the person's brain is healthy. They don't have a tumor, they don't have another illness that needs to be treated separately.
They will scan their brain anyway.
Yes, so all these things are excluded. This is what we call organic psychosis, but this is usually excluded. And I think now I'll move on to schizophrenia, if
Please
that's
do.
okay.
Yeah, please
Now,
do.
schizophrenia is an uncommon condition. It affects about 1% of the population anywhere in the world. In the UK, at any one time, there would be between 300 and 600,000 people who have schizophrenia. Unfortunately, schizophrenia starts at a young age. So it really affects people's lives. Sure. It starts usually between the age of 15 and 25. And also, unfortunately, it is a chronic illness. It tends to go on. However, the positive message is that the earlier we recognize it, the better we can control the symptoms. So it's very important when you're worried that your child, your son or daughter may have some strange behavior, they change their behavior or whatever, just go and see your primary care doctor, your GP, just to double check things. And if the earlier they get treated, the better. And now in the UK, there are units, special units in lots of areas, which look at young people and trying to pick up those young people who are considered to be more vulnerable to schizophrenia, either because they have a family history or because there's something else in their lives that makes them more vulnerable, to support them, to help them with psychological methods and with psychosocial interventions to try and limit the occurrence of the condition. But again, once it presents, if it's treated promptly, it can be well controlled and people can still have good lives in the long run.
Okay. Is it a lifelong treatment most likely? To say for the viewers. It's a chronic condition, but if treated early, maybe in a small number of patients, it may not need lifelong treatment. But if it does, we have a wealth of medications these days that we can tailor the medication to the individual so it doesn't affect their life so much, and they can actually have a good life and function well without all the drawbacks. And I'll come to the drawbacks of the illness and so on in terms of health. Because, you know, at this age, it's very difficult to say to a young teenager, take this antipsychotic treatment. He doesn't want to be compliant, he wants to go out, he wants to socialize, he feels very uncomfortable taking them.
Yes.
So obviously, the management of the disease is not very straightforward at this age.
Yes.
Under the age of 20 usually.
Well, it is, and I understand that because young people want to have a normal life as they see it, and the problem is when they're unwell, they cannot have a normal life because that affects the way they interact socially with other people. Yeah. And other people would avoid them because they think, oh, their behavior is strange, or be wary of them. While if they take the medication, then they can have a normal behavior and interact with other people and have a normal life. So there are positives there that young people need to consider. You don't need to tell your friends if you feel uncomfortable about it that you're taking medication. Usually these medications are taken once a day, usually at night. Nobody needs to know you're taking medication.
Right. Shall we say, because we are running out of time, unfortunately, shall we say a few things about the etiology and pathogenesis? What is causing schizophrenia? Because many people would ask why at this young stage of life you're diagnosed with such a horrible disease.
Yes. There are, like other psychiatric disorders, there are various factors involved. Of course, genes are important. There's no single gene that we have identified that is responsible for schizophrenia. But there can be vulnerability. If there's a family history, then obviously there's some genetic predisposition. It doesn't necessarily mean one is going to develop schizophrenia, but genes may be responsible in some cases, then what we call neurodevelopmental abnormalities, our brain grows and continues to grow even after we are born. So not many people know, but our brain continues growing until the age of about 20. So those bits of the brain that concern higher function, like our behavior, our judgment, our thinking, continue maturing in our teens. So the brain is vulnerable during that time, and there can be some malwiring of the brain that can cause, can bring about this condition. And of course, psychosocial stress, psychological stress or social stress can trigger an episode of illness or can cause a relapse of illness. So these are the main factors involved in the development of the condition. What else would you like me to say?
Whatever you want in the last. We have to finish that first part, unfortunately. So in the next 2-3 minutes, I'll leave it to you. Whatever you think is more important.
I think I could mention the physical health of people with mental disorders, in particular schizophrenia. Now, the nature of schizophrenia as such is that people are less motivated, particularly if they're not taking medications, sit around a lot, doing very little, not caring well enough for themselves in terms of exercising, their lifestyle in general, eating the right food and exercising, so they may put weight on. Or if they become sick, they won't go to the doctor for physical illness, they won't go to the doctor, so illness then gets worse. So people can die, there is evidence that people die earlier because of all these reasons. So it's very important for us doctors to be proactive and make sure we care for the physical health of our patients as well as for the mental health. And because of the weight gain, and because some medications also may encourage if there is vulnerability to diabetes and so on, we need to take care of all these things, otherwise these conditions can develop and then cause cardiovascular problems in the long run. So it's very important both for the family and the person who has the illness, also for us professionals, to take care of all these matters. And I've got here a couple of accounts from patients. Can I read them out? It'll only take a minute. The first patient says, I began to think, this is just to show you how the illness can present itself. She says, I began to think that my blood had been poisoned by evil spirits and that I was evil and that there were spirits around me warping my thoughts and changing my thoughts, and that was very frightening and I didn't know what to do with it. So you can imagine how uncomfortable this state can be. And then another patient says, I was constantly being bombarded by terrifying voices. I believed they were all powerful entities that were always right. One of the voices I heard claimed he was the devil. Another threw lewd insults at me, such as whore, and told me he could kill anyone he wanted if I didn't do what he said. Another controlled what I ate and berated me with insults about my appearance. I fitted the voices I heard into my elaborate theories on life that to everyone around me sounded like nothing more than the mad bubblings of insanity. Theories of parallel universes, evil spirits, government conspiracies, and special communications with the underworld and Satan himself. So this is a person who recalls what she was like when she was ill, now healthy, well controlled with medication. So you can see what a different sort of world he was in at the time.
So that is the message, to understand what is going on
and
roughly
please
in their
get
mind.
treatment, and please get treatment because treatment can work, it works.
Family and friends to support people with this mental health disease.
And this is illness, like any illness, it can be controlled, is not part of the person.
Indeed. Okay. That was wonderful. Ο χρόνος μας δυστυχώς πάντα δεν φτάνει, πάντα είναι λίγος. Είναι τόσο πολλά να πεις. Θα μπορούσαμε να μιλάμε ώρες και ατελείωτες μάλιστα για όλα αυτά και εμπειρίες ασθενών. Πάντως είναι παρήγορο ότι μπορούμε να πούμε μέσα σε λίγη ώρα κάποιες έννοιες, να τις διαχωρίσουμε, να εξηγήσουμε πώς διαχωρίζουμε την ψύχωση από τη σχιζοφρένεια ή να καταλάβει ο κόσμος τι συμβαίνει στις περιγενετικές διαταραχές, στις ψυχιατρικές. Τουλάχιστον κάποιες βασικές πληροφορίες και κάποια στοιχεία για τους τηλεθεατές μας να καταλάβουν κάποιες βασικές έννοιες της ψυχιατρικής.
Ναι.
Ευχαριστούμε πάρα πολύ.
Και εγώ ευχαριστώ.
Για όλα αυτά που μας είπατε και για όλα αυτά που μαθαίνουμε, γιατί και εγώ γράφω, σημειώνω πολλές φορές, είναι χρήσιμο όλα αυτά. Θα ευχαριστήσω και τους τηλεθεατές μας που ήταν κοντά μας. Θα κάνουμε άλλη μια εκπομπή με την κυρία Παλαζίδου σχετικά με την άνοια, μεγάλη μάστιγα της εποχής, και το NHS στην Αγγλία δίνει πάρα πολλά πλέον για την άνοια και θέλει ιδιαιτέρως οι γιατροί και ειδικά οι GP να ασχολούμαστε με την άνοια. Υπάρχουν πάρα πολλά επιδοτούμενα προγράμματα. Θα τα πούμε όμως στην επόμενη Κυριακή με τους τηλεθεατές μας. Ευχαριστούμε που ήσασταν μαζί μας. Καλό βράδυ, καλή εβδομάδα. Ραντεβού την επόμενη Κυριακή.